Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 48th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled "What is Pain Management?" is being recorded so that you will be able to revisit it again. Please feel free to tell your friends and family about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. Being in pain can impact every aspect of our lives, from home to work to play, and it can even affect our sleep. Pain can be debilitating and very frustrating. Whether you're suffering from sudden pain or chronic pain, finding the right help is important to enable you to take control of your pain. Tonight, Illinois Bone and Joint Institute's Craig Malk, MD, will teach you about the treatment options available to improve your functionality and quality of life. Dr. Malk is a double board certified anesthesiologist and pain management physician. He completed his anesthesiology residency at John H. Stroger Jr. Hospital of Cook County in Chicago, and then stayed on to pursue a fellowship in pain management. Prior to joining IBJI, Dr. Malk worked in private practice at both Advocate Lutheran General Hospital and Elmhurst Hospital, accumulating years of experience treating patients. His areas of expertise include, and I'll warn you, this list is long, but I don't want to leave off any in case you're looking for someone to help with your specific type of pain. So here we go. Botox injections for migraines, cancer pain, complex regional pain syndrome or CRPS, dorsal root ganglion stimulation, epidural steroid injections, facet joint medial branch nerve blocks and radiofrequency ablation, genicular nerve blocks and radiofrequency ablation, intercostal nerve blocks, medical management, minimally invasive lumbar decompression, occipital nerve blocks, sacroiliac joint injections and radiofrequency ablation, spinal cord stimulation, sympathetic nerve blocks, trigger point injections, ultrasound-guided joint and bursa injections, and ultrasound-guided peripheral nerve blocks. And if you counted, that was 17. I'm sure there are more as well. Because he understands the profound impact pain can have on a person's life, Dr. Malk employs, maybe he enjoys it too, probably, a multidisciplinary approach to treat both acute and chronic pain conditions. He also understands the complex nature of pain, which is why he provides a comprehensive and individualized treatment plan for each and every one of his patients. Your pain is different from everyone else's pain. No two cases are exactly alike. Therefore, everyone's treatment plan will be unique. Dr. Malk may incorporate a combination of treatments including medication management and physical therapy, as well as minimally invasive procedures to restore function and help improve quality of life. Dr. Malk says providing patients with compassionate and individualized care helps build a solid foundation so that we can achieve our goal of a pain-free lifestyle. During Dr. Malk's presentation this evening, you might find that you have questions, which he will be happy to address at the end of the program. Simply type your questions onto the question section on your screen, and I will receive them and relay them to Dr. Malk immediately following his presentation. I do ask that you please keep your questions general, as Dr. Malk will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Malk via one of the options that will be listed on the slide shown now and during the question and answer portion of the program at the end of his presentation. One last thing before I turn the evening over to Dr. Malk. Please mark your calendar for our next IBJI and YMCA Education Series program on Thursday, February 22nd at 7 p.m. Dr. Craig Forsthoffel will answer the question, what is spinal stenosis? Thank you again for joining us tonight, and thank you, Dr. Craig Malk, for your time and effort in putting together this program to teach us about pain management. Dr. Malk, please take it from here.
Thank you, Karen, for that fantastic introduction. I appreciate it, and I look forward to speaking with you guys tonight. All right. So my name is Craig Malk. I'm an anesthesiologist and pain management physician here at Illinois Bone and Joint. As Karen said, I did my anesthesia training here in Chicago at John H. Stroger or Cook County Hospital of Chicago. And then I stayed on to do a year of interventional pain management. And I am here tonight to explain to you what exactly it is we do on a day-to-day basis. So we've often heard the term pain management, and I know a pain doctor, and he does some injections on me, but what do we actually do? What is our practice? What do we do, and what do we bring to the practice? What do we have to offer our patients? So we split this up first into what is acute pain. So in my practice, I deal more nowadays with chronic pain management, but to get to that, first we have to deal with what is acute pain. So acute pain is a neurophysiological response to a stimuli, to a noxious stimuli, to an injury that has occurred recently, typically in less than 3-month duration. So you're oftentimes having a fall at your home, and you get that sense of immediate pain to your arms, your limbs, your back. So the typical presentation is a clear-cut cause. All right, you fractured your hip, and you need to go see your orthopedist. And that pain that you're experiencing for that acute duration before it subsided is relatively brief, and it subsides as that healing is taking place. But oftentimes, when patients experience pain that is beyond that 3-month duration, we consider that to be chronic pain. So it's usually between a 3 to 6 month duration that pain persists for, and it becomes just beyond that normal time of wound healing. And a lot of times when patients experience chronic pain, they are experiencing this secondary to several underlying diseases. This could be related to a cancer pain. This could be a chronic nerve pain relating to diabetes. This could be relating to a patient who has had spinal surgery, and now they have traumatic pain postoperatively. This could be from a chronic nerve entrapment. So this could also be relating to conditions that, where the cause is not so known, where patients have a history of something called fibromyalgia, or they have just nonspecific low back pain, and they are presenting to our office for an evaluation, which is what we do. So we rely on evaluating patients. We rely on our practice where we have to diagnose and what's going on, and then we offer several different treatment options. So what we do on a day-to-day basis is we evaluate the specific cause of your pain and any of the underlying conditions that relate to it. And many times we call these pain generators. So whether this is a generator in the spine from degenerative disc disease, whether this is osteoarthritis from your knee pain, or osteoarthritis involving the hips or the spine, whether this is a nerve-related pain from diabetes or chronic nerve injuries, or just if this is muscular pain. So that's what our goal is, to evaluate you, to see which of these pain generators are causing you the most amount of pain. And then we have to diagnose this. So, without just looking at the patient, we rely on doing a physical exam on our patients. We rely on x-rays. We rely on MRIs. We rely on CT scans. We rely on EMGs, or nerve conduction studies, to help us pinpoint exactly where in the body these pain generators are coming from. And part of my practice as well is to do what we call diagnostic injections as well. And we will get to that a little bit later on in the talk. And then the next step in what I do is I come up with a treatment plan. And that could be anything from medications that I'm prescribing for patients. That could be anything from injection therapies, or referrals to physical therapy, occupational therapy. So a lot of what we do is not just seeing our patients and doing the injections and prescribing medications, but we also coordinate treatment between multiple specialties. So I may refer one of my colleagues or one of my patients to one of my surgical colleagues for an evaluation of the spine or the hip, things that are out of my scope of practice, but that's what we are there for. We are there to help coordinate this care. And if my patient needs to go to these spine physicians or sports medicine physicians or physical therapy, I'm there in the office to help coordinate that. Some of the painful or chronic pain conditions that we see on a day-to-day basis are things like degenerative disc disease of the cervical or lumbar spine, cervical or lumbar radiculopathies, which is that sciatica type pain that we often experience, facet disease, which is basically osteoarthritis of the spinal joints, spinal stenosis, and I will explain what spinal stenosis is during this lecture, but you'll also get a much more extensive lecture I hear from Dr. Forsato a little bit later on in the year. Some joint arthropathies of the hips, knees, shoulders, chronic regional pain syndrome, or CRPS, which is a rare condition that we're seeing a lot as pain physicians. Post-laminectomy or failed back syndrome, which is a condition that can occur after somebody has undergone previous spine surgery and then they develop a chronic back pain or chronic nerve-related pains of the upper or lower extremities, chronic headaches, and cancer pain, just to name a few of the conditions. So we employ a comprehensive pain management practice here. We rely on multiple modes of therapy, and we utilize a multimodal, which is a common term seen and said amongst pain physicians, because that's what our treatment relies on, multimodal approaches to try and get the best care for our patients and the best outcome. So we rely on what we do. We rely on physical therapy, chiropractic therapies. We rely on medication management, behavioral therapies, behavioral modifications, diagnostic imaging, and then the interventional pain therapies, what I specialize in, which is injection therapies and surgical interventions. And we put a lot of emphasis on physical therapy because we really incorporate that tremendously in our practice. We rely on our wonderful group of physical therapists and occupational therapists here at IBJI, because we utilize a lot of stretching exercises in our treatment regimen, our treatment algorithms. We rely on core strengthening. We rely on aqua therapy for a lot of patients who may have chronic knee or hip osteoarthritis, and aqua therapy is great for those types of joints because you're kind of like weightless in the water, but you're still gaining all of that strength. Other therapies such as massage therapy, ice heat, TENS unit therapy, or electrical stimulation, dry needling, these are all things that we encompass in our practice. And then medication management. As years ago, when pain management became more of an interventional specialty, medication management was the basis of what we did in our practice. But we still use a lot of medications today, anything from topical agents like Salon Pause patches for just ongoing axial pain, certain conditions, Aspir cream, Voltaren gel, which is actually an anti-inflammatory gel, which is very, very good for joints. Things like Tylenol, over-the-counter NSAIDs like Advil, Aleve, diclofenac, naproxen. And then we as specialists have the ability to monitor, to prescribe, to tailor medications, things like stronger medications, things like opioids. And you may have heard of medications like tramadol, hydrocodone, or Norco, or oxycodone, things that has gained quite a lot of popularity over the last 20, 30 years because there was so much, there was quite a lot of horror around the US with prescriptions and overprescribing and patients becoming addicted. But we as pain physicians have the ability to tailor these medications and to monitor them, and this is just part of the scope of our practice. All right, and then moving on, some of the other things that I work with are interventional pain therapies. So on a day-to-day basis, we're going to utilize injection therapies such as epidural steroid injections, joint injections of the shoulder, the knee, the hip, facet or nerve blocks of the spine, whether that's the cervical or lumbar area, and then radiofrequency ablation, which is a type of procedure that has become very, very popular, very common, and we will discuss that. Botox injections for chronic headaches or muscle spasticity, PRP injections, which is gaining a lot of popularity. Surgical therapies, which I have to offer, are spinal cord stimulation, intrathecal pump placement, a Vertiflex placement or Superion, a minimally invasive lumbar decompression for ongoing spinal stenosis, and then peripheral nerve stimulation. So now we're going to move on to what specific types of therapies we will discuss this evening. So when it comes to joint therapies, specifically the knee, the goal of knee therapy or injection therapies of the knee, the primary goal is to reduce pain and inflammation. Our other goal is to improve mobility with our patients. Our third is to improve the response of these treatment and therapeutic programs. So all this basically equals patients are walking, standing, and functioning better on a day-to-day basis. We utilize a lot of these injections to help patients, regain their strength after surgery, before surgery, if they're not candidates for surgery. We utilize these therapies in conjunction with physical treatment, physical therapy, and other occupational treatment programs. So when it comes to knee injections, there are three areas that we typically focus on as pain physicians. The first of which are steroid injections. Now, steroid injections are a pretty common injection for any kind of physician nowadays. They're doing them in primary care offices, they're doing them in the emergency rooms, they're doing them at a lot of our orthopedist offices. So, but what steroid injections do is that they reduce inflammation. Some of them are different formulations of the steroids. Some of them act longer and give a longer lasting relief than others. But a steroid is a very simple and quick way to reduce inflammation within joints, whether that's the knee, the hip, the shoulder, the back. And by using these steroids, patients can very quickly regain a lot of their strength. However, steroids have limited ability to completely help. What you're not doing is you're not regaining structure of the knee. You're basically just decreasing inflammation in that area. But steroids have limited ability. Not every patient can take steroids. Steroids may end up not working. So then we rely on other types of medications like viscosupplementation, which is basically when patients have a lot of wear and tear of their knee from chronic osteoarthritis, they lose a certain fluid that helps with absorption and shock within the knee joint that acts as a lubricant because some of that cartilage has worn down so much over time. So this hyaluronic acid, which is a certain type of gel injection, is able to be injected into the knee joint and kind of act as a replacement and allow that joint to move a little bit more smoothly than it would without the gel. Then we also have the ability to do what we call radiofrequency ablations of the knee, which is a fairly newer modality, probably gained a lot of popularity in the last 10 years. And a lot of physicians are doing them on a daily basis. And we'll go into more of that, what it is. But so here we go, radiofrequency ablation. So it's actually a thermal destruction of sensory nerves. So what that means is basically we are destroying nerves within joints or nerves within the body. And specifically, this is a sensory nerve. Well, what that means is this is a nerve within your body that senses pain coming from that joint. This does not allow you to function. It does not allow you to completely stand on that knee. So by destroying these nerves, you are not going to lose that ability to walk. You're not going to lose your ability to function. You disrupt the sensory input from these joints, whether that's the spinal joints, whether that's the knee or hip joints. And the way we do this is there's usually a 2 or 3 step process where we conduct a series of nerve blocks. And so a patient may come into me and say, I'm having a lot of pain coming from the knee joint. So what we do is we place several needles around the knee joint and we put a longer acting local anesthetic around those joints into specific areas of the knee that produce a lot of pain coming from that joint. And what we're doing is we are creating a scenario where that patient is able to walk on that joint without as much pain. And it's a diagnostic block. The first one is a diagnostic block. So we put the medication in, the patient goes home typically, will walk around their home. They get a good sense of how much relief they would be getting should those nerves, or those sensory nerves, not be there. And after that, if they get good relief, then we can do this ablation procedure where we burn these, and I will show you exactly how we do that, but it's a thermal destruction. We're destroying it through heat. And patients can typically get usually about 6 to 12 months relief from this knee ablation, excuse me. So as you can see, there's a little bit of anatomy overview. That's the femur right there, and then there's the knee joint right there in the middle. And it's innervated by some branches of various larger nerves, including the femoral common nerve, saphenous nerve. But what these nerves are, they're cutaneous, which means, very thin. They're they're sensory nerves, all right? And all they're really doing is sensing pain coming from this knee joint. So when we talk about this procedure, we're not saying we're getting rid of the arthritis. We're just really getting rid of that pain that these sensory nerves are producing to this joint. And there's a picture on the left here that can show where our needles are typically placed along this knee joint here. And through various anatomical dissections over the years, they found that there were these sensory branches of these nerves that were causing pain specifically from these joints. And this is a procedure, a radiofrequency procedure on a patient who has had a total knee arthroplasty. And you can see on both knees, actually. So this procedure is typically reserved for patients with chronic osteoarthritis, maybe before, or maybe they're not ready to have a total knee replacement, and maybe they're looking to delaying it, or maybe for various medical reasons they can't have a total knee replacement. This would be a very good modality for them. And then afterwards, should they have any pain post-operatively, this is a very good treatment post-operative. I've had a number of patients who have come see me for whatever reason. If they're still having just a little bit of knee pain after the prosthesis is in place, even though the hardware is stable, they're still having persistent pain, and they come and see me, and we try this, and it has been very, very therapeutic for them. And this is just showing the lesioning of the procedure. Okay, so we use a lot of diagnostic imaging to confirm that our needles are in the right place. These are the types of needles on the far left, on the far right. Okay. All right, so then we're going to move on to some spine therapies. Spinal therapies are a bread and butter for our practice. So a lot of indications that we see, patients, for example, will come in and see us and say, or they'll be referred to us, and they have a lot of ongoing back pain. They have a lot of sciatica pain. They have a lot of spinal stenosis. They've got a lot of just aching pain of the back that is just unrelenting every morning when they wake up, and it takes them an hour to get out of bed. So it's our job to diagnose what's going on with their back and figure out which of these pain generators are causing them the most amount of pain. So we utilize spine injections such as epidural steroid injections of the lumbar, thoracic, cervical spine. We utilize facet blocks, which are the facet joints are and I'll talk about them more. We utilize these blocks to determine where in the spine these pain generators are coming from. So this is an example of a lumbar epidural steroid injection. I imagine that a lot of us have heard of or have a family member that's had these in the past. This is just showing you exactly what we're doing, because a lot of our patients come in, they're maybe laying down, and they don't actually get to see what we do. But a lumbar epidural is an injection of cortisone or a steroid into the epidural space, which is a space within the spine that houses a lot of the nerves and the spinal nerves. So the steroids that we're injecting into the spinal space reduce a lot of the inflammation around the spinal discs and then nerves. And patients, patients typically will get a lot of significant relief from this. And this is just showing us exactly how we're doing it. That's actually not me, but that's I think that's a colleague of mine. But basically, we use a fluoroscopy machine, which is like a lifetime X-ray machine that can help guide our image placement, our needle placements. So epidural injections are very commonplace in our practice. We utilize them for a lot of degenerative disc disease, for sciatica type pain, for nerve diseases of the spine. And oftentimes patients will ask, how long do these epidural injections last? Why am I getting this done if it's so short-lived? But last anywhere from 3 to 6 months. They may be repeated 3 to 4 times on average per year. And it can give patients a lot of good relief. And every patient is different. We treat every patient differently. So we always start with one injection, or in my practice, I always start with one injection. I reevaluate a patient after 2 weeks and see how they're doing. And if they need another injection, we will discuss that on future visits and things like that. But I think that this is just showing you exactly how we implement epidurals in our practice. And okay, and this is an example of the needle being placed during the epidural injection. And that black stuff that's kind of spreading on top of the needle, that's actually contrast dye. So it can spreading upwards into what we call the epidural space, where it houses a lot of the nerves. So as you see, it's a very targeted approach to help manage, sciatica type pain. We call radiculitis, which is inflammation of the nerves, spinal stenosis, and then other nerve conditions. So I want to discuss the next thing when we're talking about spine therapies. A very common ailment is, we call it facet arthropathy. So it's basically a fancy way of saying there's facet arthritis, or there's joint arthritis within the spine. Just like there are painful joints of the hip, the knee, the painful joints in the back, which is what we deal with a lot, are called your facet joints. And over time, through a lot of wear and tear, a lot of bending over the years, these joints can become very arthritic. And these facet joints, they typically will allow for bending, twisting, and alignment of the spine. Typically, they'll have spinal nerves that come off between, as you can see, there are discs in between each vertebra, highlighted in purple there. And oftentimes, these joints that are between, all run up and down your spine, they oftentimes are associated with what we call chronic axial low back pain, which is basically the pain that you may experience when you're waking up in the morning. You're very, very stiff, you're aching, you have a tough time getting out of bed. We typically don't see any what we call sciatica type symptoms with this type of joint pain, but this is what patients might come in, for example, and just say, doc, my back is really aching today. It's all along my belt line, and oftentimes we'll kind of know right off the bat that it sounds like it's facet joint arthritis. But we can't be too sure. We don't know, we have to do a series of diagnostic blocks. So as we had talked about before, we do these diagnostic blocks, usually a set of 2, for purposes to properly diagnose the problem and then confirm that this is exactly where this pain generator is coming from in the spine. So what we do is, we'll look at the MRI, we'll examine the patient, we'll see, which levels of the spine are being affected. And what we'll do is we'll place some local anesthetic within the spine, guided using X-ray guidance as well. And we will place these, the local anesthetic within these joints around the joints. And then the patients typically will go home, they will walk around, they'll see if they're getting any relief from these facet blocks. And if they're getting relief, that's, and what we're looking for is roughly about a 75–80% relief from these diagnostic blocks. And we know that they're short-lived. They're not going to last beyond basically a day, because that medicine will wear off. So if the patient says, I only had pain relief for maybe 4, maybe 6 hours, that's a positive diagnostic test for us, because that means that, yeah, okay, we know the medicine wore off, but during that time period, you were able to walk around, you were able to do things that would normally trigger your pain. So we do one more set as a confirmatory block. And if that is successful, then we move on to what we call a radiofrequency ablation. So just like we had the radiofrequency ablation of the knees, we do it the same thing in the spine. And so just to review here, we use radiofrequency ablation, which basically heats up tissue around those nerves. And so oftentimes the patient will come in and say, I heard about this burning of the nerves procedure. Well, what that is it's a radiofrequency ablation. It's an RFA. It's a procedure where we can burn these little nerves surrounding the joints within the spine. Patients typically will do very, very well with this type of procedure. They can get relief anywhere from 6 months to, I would say, about a year and a half. And then the ablation procedure can be repeated over time. So this is something that is done for the lumbar spine. This is something that we do for the thoracic and cervical spine. Patients who, may have coexisting disease processes like lumbar radiculopathy or sciatica type of pain, and still may have persistent back pain. Well, we reevaluate them. They may be a candidate for this ablation procedure. Okay, so moving on, I want to talk about another area that we focus on here. Okay, so spinal stenosis is another condition that affects a lot of us as we age. It's from a lot of wear and tear over the years. It becomes a natural phenomenon in a lot of the population. So what is lumbar spinal stenosis? Well, it's a condition in which the spinal canal narrows and compresses the spinal nerves in the lower back. This leads to a kinking phenomenon. They just best visualized as a kink in a straw, and this can compress these nerves and cause a lot of pain and mobility issues of the lower legs. So, like we were saying, what are the causes? Well, there's natural wear and tear of the spine as people age. That can lead to a number of contributing factors. There can be an overgrowth of what we call the ligamentum flavum, which is a ligamentous tissue within the spine. That could be thickened over time. There could be overgrowth of bone or osteoarthritis from your facet joints, as we had previously mentioned. You can have bulging of discs within the spine that can all lead to this kinking phenomenon. Symptoms, what do patients experience? Well, they experience pain, numbness, inability to walk, pain in the lower back, especially when they stand upright, pain and numbness, heaviness with walking. And typically the symptoms are alleviated either by rest or by bending forward. Why you say bending forward? Well, I'll show you in this next picture. This is a very common picture that we see with lumbar spinal stenosis. So the gentleman on the left, as you can see, he's walking, he's standing upright, and it's provoking a lot of symptoms going down his lower extremities, all the way down to his feet. We call this a claudication symptom, right? Because that spine is upright, it's compressing those nerves within the spine and those spinal nerves that are coming out. And it's leading to weakness of the legs. It can affect the buttocks, it can affect the back. And why bending forward we had alluded to? Well, this is called the shopping cart sign. So a lot of times we'll see patients who are walking around the grocery store and they're leaning forward on a cart. Why are they leaning forward? Or, why are they so much ease with this kind of movement? Well, that's because they are flexing their spine. And by flexing the spine, they're taking a lot of pressure off of those spinal nerves and that compression. So this just creates, their bodies just adapts to this problem and creates a sense of pain relief for them, a natural phenomenon. So when they stand right up straight, it goes right back to that shooting pain down the legs. So one of the procedures that we offer for lumbar spinal stenosis is more of an advanced procedure, interventional procedure. It's a minimally invasive procedure. This is called the Vertiflex procedure. And what it is basically, we call it an interspinous spacer. So this is a spacer that is placed within the spine. This is on the right, you see x-rays of the spacer device and a side view of where the spacer is placed. But what it does is when this gentleman who was standing up straight is now, it opens up the space and allows those spinal nerves to not cause as much pain. So when that gentleman does tend to stand up straight, they're not producing as much pain going down the nerves and down the legs. So a lot of patients who may be candidates for this procedure will have evidence of spinal stenosis. It's FDA approved at a number of levels within the lumbar spine. It is not approved for cervical spine, but it is certainly approved for lumbar spinal stenosis, and it has offered patients a lot of good relief. Procedure's been out for about 7 or 8 years, and it's a minimally invasive procedure. So patients will just require a little bit of sedation and local anesthetic. It's usually done at an outpatient surgery center, and usually takes about half an hour to do. Patients are home that same day, and but this, as we say, an interventional procedure. This is after the patient has already tried most other things like ongoing physical therapy. They've tried injection therapy. They may have even tried ablation therapy. So this is another modality that we have to offer. So spinal stenosis also, it's a very prevalent condition. So another thing that we can offer them is something called the mild procedure. And what the mild procedure does is it treats a condition of spinal stenosis by removing this thickened ligament tissue within the spine. And we alluded to before, this thickened spinous tissue can cause a lot of compression of the nerves within the spine and those nerves down the leg. So this is another minimally invasive procedure where we go in and we make a very, very small nick in the lumbar spine, an incision just as small as what we call as a baby aspirin, and we put a cannula in there and we scrape out some of this overgrowth tissue that is causing the spinal stenosis. Patients go home that same day, and they usually get relief probably within a couple of months. And this can be, a game changer for them. But obviously, we have also tried other injection procedures for these types of patients. But nowadays, people are moving towards trying this mild procedure as even a first-line measure if they know that epidural injections after epidural injections have not improved any of their pain symptoms. We're going to attempt to try to see. I can show you this mild procedure. It's actually a very 2-minute video where we can just take a look and just see what's going on and what they're actually doing in this procedure. So bear with me here. Let's see if we can. I don't know if you can see this.
Yes, we can see it, Dr. Malk.
Okay.
It looks like it's coming up, right?
Yeah.
The mild, minimally invasive lumbar decompression procedure represents one of the greatest advances for interventionalists treating patients with lumbar spinal stenosis, or LSS, with neurogenic claudication. This minimally invasive outpatient procedure offers a safe and efficient means of providing LSS patients with significant mobility improvement and pain reduction. The mild procedure requires no general anesthesia, steroids, or opioids, and removes a major root cause of stenosis while leaving nothing behind, no implants, and no stitches. In LSS, hypertrophy of the ligamentum flavum is common and responsible for up to 85% of central canal narrowing. In fact, a 2-year level 1 study showed that 95% of LSS patients exhibiting central canal stenosis also presented with other contributing comorbidities. But just 5% of patients had central canal stenosis only. Mild focuses on the debulking of the hypertrophic ligamentum flavum, addressing the problem directly. Its safety profile is extremely robust. It has been clinically proven to be equivalent to an epidural steroid injection, with no device or procedure-related serious adverse events or complications reported in any clinical trial. The entire procedure can be performed through a single tiny incision using a narrow, stabilized, depth-limiting portal under still and live image fluoroscopic guidance. The mild bone roger enables clearance of any obstruction posed by osteophyte growth, providing direct access to the target area. The mild tissue sculptor is uniquely designed to efficiently engage and debulk hypertrophic ligament, allowing for multiple passes before momentary removal and cleaning. Once successful decompression is achieved, the incision can be closed with an adhesive strip. Patients typically resume normal activity within 24 hours with no restrictions. Mild Superb, clinically proven safety, efficacy, and durability make Mild the next step for LSS treatment after failure of conservative care. To learn more about the Mild procedure or to become a Mild trained physician.
Okay, let's get back to where we were. Okay. Hi there, everyone with me?
Yep, we're still following.
Okay, very good. All right. All right, so that was the Mild procedure. And then let's dive into another topic that is extremely popular and has gained a lot of attention for pain physicians, I would say, over the last 20 to 30 years. So it's called spinal cord stimulation. So what a spinal cord stimulator is, an implanted device within the spine that sends low levels of electricity directly into the spinal cord, and what it's doing is doing that to relieve pain. So by placing this stimulating electrode over the spinal cord, the pain signal cannot be sent up from the spine to the brain. A lot of times we relate this to if you banged your knee and you are rubbing your knee significantly. There's a lot of rubbing going on of your knee that kind of makes that area feel good temporarily. Well, we relate this to the spine. So when we put these electrodes in the spine, we stop those nerve impulses from going to the brain center, and so stopping the signal going to the brain, and you're not sensing as much pain going to that painful area. So that's the idea behind spinal cord stimulation. So who's a candidate? Well, typically if you have chronic low back pain, if you have failed other therapies, including epidural injections of the back, ablation procedures of the back, if you have, undergone previous lumbar laminectomy or fusion procedures of the lumbar or cervical spine, and you just have chronic radiating pain or chronic neuropathic pain after those types of surgical procedures, those patients are great candidates. Injuries to the spinal cord, nerve-related pain, diabetic neuropathy, cancer or chemotherapy-induced neuropathic pain, chronic regional pain syndrome, which is a very rare pain condition where the autonomic nervous system and sympathetic nervous system of the body wiring gets crossed and leaves behind patients with just chronic painful limbs and lower and ailments of the body. And then patients who have peripheral vascular disease can also be very good candidates for this procedure. And what we're doing here is it's a two-step process. We use a trial phase. So we basically will do an epidural injection for the patient, and this is all sterilely done. This is done in an operating room setting, done with a little bit of light sedation. Patients will go home that same day. But the trial phase is usually where the electrodes are placed within the spinal canal, and the goal being at least a 50% reduction of their pain during that 5 to 7 day trial phase. And we are looking in their overall reduction in pain. We're looking for an improvement in their function. We are looking, we want them to be comfortable with this device. And if they're getting at least a 50% reduction in pain, most of the time that is significant for a lot of our chronic pain patients. And if successful during the trial phase, then we would move on to the implantation phase, where we implant this, what we call it, a pulse generator, which is basically the size, it's a battery, it's the size of typical pacemaker or even smaller. And this gets implanted in just below in the tissues, kind of like around the buttock area. And patients do very well with this procedure, especially if they've done very well with the trial phase. These are all minor outpatient procedures. They're done under just a little bit of twilight anesthesia. There's no need for general anesthesia for most of these cases at all. This is obviously a last step procedure. This is a procedure that we will typically utilize for our patients once we've tried all. They've had years of physical therapy. They've had months of epidural injections, and they've tried everything else. This is just something that we can offer to our patients. And it's a very good modality for chronic nerve pain, for chronic low back pain, and in the right setting, it can be a game changer. It can be life changing. Okay, so I've gone over a bunch of our bread and butter procedures that we will typically utilize on a day-to-day basis. I've gone over a few procedures that are more interventional, more minimally invasive procedures that we may do in the outpatient ambulatory setting. We offer a lot of different treatment options in our clinic here and part of our practice. And I leave it open to questions because I feel like we can gain get a lot more things asked once questions are asked, and we can go from there. So thank you for your time.
Well, thank you, Dr. Malk. This was, for me at least, one of the most fascinating presentations that I have attended, and I've been to 48 of them. But this was really a lot of really cool, good information, so thank you. All right, so our first person you already discussed, over-the-counter pain medications, and which is best for which different kinds of pain. Do you have anything more to add to that? Are there certain over-the-counter medications for pain that are better than others for treating certain parts of the body or certain types of pain?
So, we honestly, the first line treatment are the over-the-counter, NSAIDs. We call them non-steroidal anti-inflammatory drugs. And we utilize a lot of these for the chronic hip, the chronic knee pain, the osteoarthritis of those joints. Unfortunately, a lot of our patients have comorbidities. They have other medical things, medical conditions going on, like ongoing diabetes, hypertension, GI issues that make these types of medications just not possible. So it's always best to either consult with your pain physician, but also with your primary doctor, whether you are able to take formulations of these over-the-counter medications. And there are some medications, prescription medications that are anti-inflammatories that are have a better safety profile for some of our patients. Things like Celebrex and Meloxicam, they just more tolerated. So it's always good to ask those questions. Those are the first line agents. Then Tylenol, has been an agent that has been tried and true for many years. Acetaminophen, they use it all over around the world and in different formulations. So that's something that our patients always rely on, just to help. It may not last forever, but getting on the right dose regimen of it might be a game changer.
And it also sounds like there are so many other treatment options now available if someone with chronic pain comes to see you, that maybe people don't even, if those over-the-counter medications aren't working anymore, boy, it sure sounds like there's a whole host of other things that you can help people do.
Yeah, absolutely. Pain management, the world of pain management has transcended, over the last 20 to 30 years. There's just tons of new data that's coming out. There's just tons of new medications that are coming out with better safety profiles. And then, we as pain physicians are relying more on interventional treatments, so injection therapies, because to be honest, most people don't want to be taking, pills all day long, right?
Right.
They'd rather, I think for a lot of patients, they'd rather have an injection than just, take another regimented pill to control their pain. So,
yeah.
It's a good modality and something that we encourage.
Awesome. Someone asks, do you treat people with plantar fasciitis? And if so, what are the best treatments for that?
So plantar fasciitis, I mean, we will, we don't see a ton of patients with plantar fasciitis. We will, do an exam on the patient. We will maybe do some x-rays to make sure we haven't missed anything with our diagnosis. But to properly diagnose plantar fasciitis, I would refer them to one of my podiatric colleagues, podiatrists, or foot and ankle specialists at IBJI, and we have quite a few excellent choices.
And it seems like people with plantar fasciitis would probably be healed before they would be sent to you. You know, something else with the podiatrist would be able to help them.
Yeah, I don't see a ton of plantar fasciitis because they usually are maybe diagnosed in their primary care's office, or they've already been sent to the podiatrist. You know, they've you know, run them through all the treatment options. So they, you know, for chronic pain relating to plantar fasciitis, I typically don't see a lot of that.
That's what I figured, but I thought, well, if this person asked, I wanted to make sure we covered it.
Yeah, absolutely. Absolutely. That was a good question. Good question.
Yeah. Yeah. Do you have aquatherapy on site? I thought that was a good question. I don't know.
Yeah, no, we don't have it on site, but we certainly, there are certain facilities around the Chicagoland area that, you know, we can refer you to. It's just, you know, after I've, you know, evaluated you, we can give you a referral to any of our aquatherapy sites that we work hand in hand with. Yeah, and we use it as much as possible. I mean, it's a great modality for osteoarthritic conditions of the knees, the hips. So we're very in favor of that. So we can certainly coordinate that care with you.
Great, thank you. All right, someone asks, are any of the treatments for knee, hip, and lumbar spine arthritis pain prohibited by a patient who is obese?
No. So, no, it's not prohibited. Let me say that. It's not prohibited at all. So that question is kind of like, well, it's almost like the chicken or the egg. Why are they having so much knee pain? Well, they may be because they are a little bit obese, and they do have obesity as one of their medical conditions. So, no, I will typically see obese patients and utilize these injections for obese patients. Now, whether, you know, depending on their BMIs, they may require some sedation, or they may have to be done at one of our surgical centers. But if they do require sedation, they may have to be done in the hospital. But typically I will utilize a lot of the RFA or the injection therapies for obese patients, because we utilize a lot of fluoroscopy, x-ray guidance within our practice. So pain physicians are well trained to deal with the obese population. That's just, you know, hand in hand with what we do. So
great, thank you, thank you. Someone asks, after burning the nerves, do they regenerate?
Great question. They do regenerate, and that, so yeah, so the nerves do regenerate. The process of regeneration varies. Honestly, it can take anywhere from 8 to 10 months all the way up to a year, year and a half. But that regenerative process, the idea behind that is during that time, you're getting the pain relief. So patients will come back, and, you know, I might not see them after I've done the ablation procedure, and I may not see them for a year. And they may say, oh, well, just a couple of weeks ago, you know, my back's, you know, started to hurt again. And then I would say, you know, any new falls, injuries, anything? No, the pain just started to come back to me. So that kind of leads me down the path of, well, you know, I think some of those nerves in your back are starting to regenerate and produce those symptoms of the arthritis. So let's potentially repeat the ablation and see how you do.
Awesome, awesome. That was one of my questions. Can you then just repeat it?
Yeah. Yeah.
What's wonderful, excellent.
Yeah.
Someone else asks. Good. Someone else asks, is radiofrequency ablation painful post-procedure?
Another good question. Typically, no. Patients will have a little bit of tenderness around the sites. We're not cutting anything. We're basically utilizing needle placements for the procedure. And, you know, sometimes I will inject a little bit of steroid after the procedure to help with some of the inflammation that may occur after I've done the burning procedure. But it's typically a very well tolerated procedure. You know, if patients decide not to have it with sedation, which most of them do, but if they do require a little sedation, we can always take them to one of the surgery centers or the hospital to have that done with a little bit of light sedation. But yeah, they may have a little bit of tenderness within their area afterwards, and they can easily just, put a little ice on it for a day. But they're usually up and walking the same day, if not the next day.
Awesome, awesome. What can be done if the ablation isn't enough after a total knee replacement?
So if the ablation isn't enough, we oftentimes will, go back to the drawing board. If we've, done injections, if we've done the ablation, there are some more advanced procedures, very similar to the spinal cord stimulation, where it's called dorsal root stimulation, where we can actually target the nerves within your spine that cause pain to that knee joint, and that's typically reserved as a last basically last ditch effort to try to help with that knee pain. But if they're still having, and this is all after we've put them through all the therapy, if we put them through all the medication regimens, and they're still having this persistent ongoing chronic pain, then we go back to the drawing board, or we utilize this other procedure, and patients do very, very well with it. It's called a DRG, or dorsal root ganglion stimulation. Or there's also peripheral nerve stimulation of the knee joint that can offer a lot of benefits as well.
Awesome, awesome. That's really helpful to know. Can RFA be used for chronic shoulder pain?
Yes, it can. Yes, it can.
Right.
It just depends on where the shoulder, which nerves are coming out. But for patients with a lot of chronic shoulder pain, there's several different nerves within the shoulder joint that can be burned off. But patients will still have to do a diagnostic nerve block prior to the ablation. But yes, it is a modality for that.
Great. And how about for severe arthritis of the digits?
Can you repeat that? I'm sorry.
So someone asked, can RFA be used for severe arthritis of the digits? So I'm guessing their fingers or maybe their toes?
Yeah, unfortunately not. That's something that, not yet at least. So RFA can't really help with that. I'm sorry, but I mean,
okay,
certainly help in other ways.
And
no, but it won't.
In your job, you're always sorry when you can't help somebody with something that they're looking to get.
Absolutely.
That's always your goal. All right.
Yeah.
Let's see. Sorry, of course, all the questions come in after you're finished. So now I'm looking to see which are too personal and which are not. Okay, someone says that thank you again for sponsoring these seminars. They find them to be very informative. So thank you for that. Someone else asks, are you taking new patients?
Absolutely.
All right, great. Oh, here's a good question, or at least I think it is. For a bunch of these procedures, do you need to have someone drive you home? A lot of these that are same day types of things.
Great question. So for a lot of these procedures, which are very well tolerated, I always encourage a patient to maybe bring somebody with them on the first visit, first injection, and see how they tolerate the injection. Any subsequent injection or therapy, they're more than welcome to drive by themselves. I sometimes leave it up to the patient, but I do, make sure that they, don't have a fear of needles, they have a fear of fainting, they have a fear of blood or anything like that. Not that any of this becomes ever bloody, but it's just everyone's a little bit different. Everyone has a different response to any kind of injections. But for most of our outpatient procedures, I make sure that they at least have a ride home, or that if they're driving themselves, they have a way of getting home should they, need time after the procedure. And we never kick our patients out after injections, but I'd say I always encourage, maybe on the first visit, it's good to bring somebody with you.
Great, thank you. Okay. Someone says, regarding radiofrequency ablation for facet joint osteoarthritis, how many times may this be repeated? Is there a risk of scar tissue buildup? And can this be done for years, or do these patients need some other treatment in the future?
Yeah. So what we typically will see, I've had patients who have had the RFA repeated 4, 5, 6 times, within their, 10 times, there's typically, we don't see a ton of scar tissue buildup after this procedure. So that's a good thing. So I would say it can be repeated multiple times over. We don't see a lot of scar tissue buildup. There's not a ton of downfall to these procedures in terms of there's no nerve damage. We make sure that there's no nerve damage. We do a series of tests. We do sensory and motor testing before we do the ablation procedure. It's part of the procedure protocol. So it's a very well tolerated procedure, and it can be repeated multiple times over. Yeah, I think that's, I don't know if I answered that.
Awesome. Yeah, so it doesn't look like they'll need to use something else down the road. They can just, if it works, they can keep doing the radiofrequency ablations as long as they need to, at least in the experience that you've had so far.
Yes, and then if that stops working, then we reevaluate the patient and kind of see, wait, what's going on? Why are you having this pain? What's the likely other pain generator in the spine? Sometimes the procedure kind of stops working, or we need to readjust something. So everyone's a little bit different, and everyone's pathology is a little bit different. So we treat every kind of patient on an individual basis. So yeah, no patient's the same.
Yep, got it. Great. Well, there are about, I don't even know, holy cow, there are a lot more questions, but it is after 8 o'clock. So for all of you who had questions for Dr. Malk who didn't get them answered, please reach out to him. He is taking new patients, and he's close by. So my apologies that we can't get to all of your questions, but thank you for coming, everyone. Thank you very much, Dr. Malk. This was really informative, really helpful, fabulous presentation.
Karen, thank you for your time, everybody, and have a good evening.
Take care. Thank you. Good night.
Good night.